Hello, friends. Welcome to a topic Arterial Blood Gas Analysis. This topic I have taken in Hindi and this time I am taking in English. So let's move. So, in this topic, I am going to talk about introduction, some technical issues, oxygenation and ventilation, and how to interpret ABG in 7 steps, respiratory acidosis and alkalosis, metabolic alkalosis, acidosis, and I'll take few example in the form of case scenario to make you understand better. So, introduction: before taking any ABG, we have to take consent from either from patients or from their relatives, and we have to explain why we are taking ABG repeatedly because many times, especially in ICU, when we are changing ventilator and we used to send frequently ABG, so relative are thinking that we are getting investigation unnecessary. So we have to explain why we are taking ABG so frequently and never interpret any ABG without clinical history because many time and almost all time clinical history gives clue about diagnosis. So before interpreting any ABG, you should know clinical history. Don't jump to interpret the ABG. Technical aspect. So, site of ABG. We all know radial artery is preferred artery because this is superficial and easy to palpate. We can palpate very easily at the level of wrist, and we can compress by direct pressure, so it can achieve hemostasis. In other arteries, say for example femoral artery or brachial artery, we cannot compress much effectively. But radial artery we can compress, so we can stop the bleeding. And no large vein in the vicinity. Many times, arterial system is going along with vein. So whenever we are taking ABG, we most of the time we puncture vein. So it gives false result. So in radial artery, no large vein in the vicinity. And ulnar artery provides adequate collateral ventilation. What is collateral ventilation? See, for this is palm. So it has two arterial supply. One is radial and another one is medial by ulnar artery. So radial artery, ulnar artery. If you are taking ABG from radial artery and suppose it got thrombosed, so it will affect this blood supply. But luckily, we have collateral from ulnar artery which supplies this palm. So before taking ABG, we have to check whether our ulnar artery is working or not. Other artery, we can take ABG from brachial artery or femoral artery. But preferred site is radial artery. And as I told you, before taking ABG, we have to check whether our ulnar artery is working or not, flow is good or not. So we have to do modified Allen test. How to do? We have to compress these two veins, radial artery and ulnar artery, and ask patient to fist repeatedly. So what will happen? It will get fail because you block both arteries. Now you have to release ulnar artery. See, you have to release ulnar artery. So by releasing ulnar artery, the palm which were pale become red again. It means even you even if you compress radial artery, ulnar artery is sufficient to supply blood supply to palm. So this is how we used to do modified Allen test to see patency of ulnar artery. Technical issues. We know that we are flushing syringe with heparin while taking ABG. If you take too much heparin, it will cause false acidification. You will get low pH, false low pH. And remember, you have to send ABG immediately within 15 minutes. You cannot wait. If you want to wait for a few hours, so you can wait 1 hour at keeping sample at 4 degrees centigrade. So if it get delay, it may give false reduction in O2 and false increase in PCO2. Why? Because blood cells are there which consumes oxygen and release carbon dioxide. So whenever ABG is getting delay, oxygen will come falsely low and CO2 will give falsely high. We should not wait, we have to send immediately. And we have to discard air bubble because air bubble has more oxygen while our artery has less oxygen. So it will give false result. It give false result by increasing PO2 and decreasing PCO2. So we have to remove all air bubble from ABG syringe. Purpose of ABG. There are two main purposes, especially in ICU and emergency. First is we have to check the cause of low oxygenation, ventilation or oxygen problem. Second thing is acid-base balance, mainly in ICU. So we take example of oxygenation and ventilation. So suppose two patients are coming in emergency, patient A and patient B, and both are having acute breathlessness. You check their saturation by pulse oximeter, and both are having 70%. So what do you think? ABG is needed or not? Definitely ABG is needed because we have to see what is the cause for hypoxia in these two patients. And surprisingly, patient A have PCO2 of 40 and patient B have PCO2 of 80. So it means patient A is having oxygenation failure because of VQ mismatch. But patient B has hypoxia due to ventilation failure. The cause of ventilation failure may be something else, means chest wall fatigue or muscle fatigue or kyphoscoliosis, whatever it is there, but it is due to ventilation failure. So you have to do ABG in all hypoxemic patient because if you don't do ABG, you would have given oxygen only to these patients, and giving oxygen to patient B will um, cause harm to the patient. It will increase further PCO2. So before labeling patient as a ventilation failure or oxygen failure, you have to do ABG to rule out ventilation failure. So now coming to our core subject, that is acid-base balance, especially in ICU. So he is a Danish scientist called Sorensen, and he has given the theory of pH. He told that pH is negative log of H plus I. It means inversely proportional. If pH is high, H ion concentration is low. If pH is low, H ion concentration is high. So at normal pH of 7.4, the hydrogen ion concentration is 40. pH 7.4, hydrogen ion concentration is 40. So we have to remember this rule of thumb: 7.4, 40. Okay. So pH is very critical. Means pH high is dangerous, pH low is dangerous. The normal pH how much? 7.4. If it is getting decreased, means pH is getting decreased up to 6.8. It is harmful. What's causing? It's causing drowsiness, then lethargy, then coma, and finally patient will not survive and will lead to death. And same thing is when pH is getting higher. So when pH is increasing from 7.4 to 7.8, what will cause? Irritability, arrhythmia, convulsions. So you can notice when pH is getting down, but pH is getting decreased, patient is in sleeping mode. See, sleeping mode, drowsiness, lethargy, coma, and death. Peaceful death. Patient is not getting any problem. But when pH is increasing, it is causing more irritability, more muscle action, more arrhythmias, more convulsions. So patient is hyperactive. Here is hyperactive. And pH is low, patient is sleeping state, hypoactive. So when pH is high, hyper, pH is low, hypo. This is how abnormal pH is harmful for patient. So principle of acid base balance. So pH is something which need to be kept in normal range. So there are three things which is playing each other. They are close friends. Who are they? They are buffer, lung, kidney. They are friends. They are playing each other and not letting change the pH. Whenever there is problem in pH, they are doing their best to keep in normal. So how they are doing? So this is something called buffer. Buffer means if any acid is coming to body or acid is going out the body. So buffers are acting which is not letting pH to change. So see this example. If there is addition of H plus ion means there is acidosis. What will happen? Bicarb, which is buffer. Most common buffer in our body is bicarbonate. So whenever there is acidosis occurs in blood, bicarbs come and attaches to H ion, creating H2CO3 and dissociate into CO2 and H2. And CO2 is going out by lungs. So you can see whatever acid is coming, bicarb is getting consumed. So say for example, 10 H ions came inside. So 10 bicarb will getting consumed to neutralize the acidosis. Inversely, what will happen if there is removal of H ion means alkalosis. So whenever there is alkalosis or deficiency of H ion, this cycle will get reverse. Means more CO2 will come. I mean, lung will not excrete CO2, not wash out CO2. So more CO2 will get combined with uh, this water against CO3, and this the cycle will go in this side, right side. So there is, will be more formation of bicarbonate, and it will escape by kidney. So you remember, if there is alkalosis, means removal of H ion. So for example, 10 H ion we have removed. It means there will be addition of bicarb by 10 units. So same proportion. So disorder of any component can lead to acid-base disorder. So these three things should be intact to maintain acid-base balance in human body. So CO2 is a marker of acidosis. CO2 is like a bicarbonic acid. So whenever there is high CO2, it means there is acidosis inside the body. While bicarbonate is marker of alkalosis. If there is more bicarbonate, there means alkalosis. So high CO2, acidosis, high bicarbonate is alkalosis. We have to remember these 2 points. Now coming to ABG interpretation. So for ABG interpretation, we have to remember this table. And in this table, the relation between pH and HN concentration, we can see in this table. So at 7.4, the HN concentration is 40. When pH is getting decrease, see decrease, the HN is getting increase. Okay, so at 7.3 is 50, 7.2 63. So there is some pattern. So HN is getting increased by 1.25 times from pH 7.4 to 6.8. So every decrease in pH by zero point 0.1 getting increased hydrogen by 1.25 times. But it is not same when HN concentration is decreasing. See, here is decreasing. So when pH is increased by zero point 0.1, so HN concentration is decrease by 0.8. So what do you understand by this? So when HN concentration is increasing, it is increase more, like a price of cylinder. So what happens? The price of cylinder is getting increased exponentially. But when when the government is decreasing price, decreasing very low. So when HN concentration is getting increasing fast, 1.25 times. But when HN is getting it is decrease slowly, 0.8 times. So this table you have to remember. So while interpreting ABG, we have to remember three values. pH 7.4 for interpretation purpose. Normal value is range. For PCO2 40 and bicarb is 24. So what is base axis? This is there in your ABG, not useful very much, but this is strong acid which would need to be added or subtracted from the substance in order to return the pH to normal. So base axis as a base means alkali. So it ranges -2 to +2. So since it is alkali, so plus, if it is more than +2, it shows metabolic alkalosis, because base means alkali. So more than +2 is alkalosis. If less than -2, it is acidosis. So you understand about base axis. Now coming to our ABG interpretation by 7 steps. In 7 steps, you have to remember. There's no other choice. We have to remember. Step 1, before interpreting any ABG, we have to check whether it is valid or not. We should not jump to interpret ABG, but we have to check the ABG which we are going to interpret is right or not. So we have to check validity. How to check? We have to calculate HN concentration by this formula. 24 into PCO2 by SCO3. So PCO2 is nominator and SCO3 is denominator. So how to remember which is up, which is down? So you remember lungs are higher, kidneys lower in the body. So lungs means CO2. So CO2 is above. Bicarb is down because kidney is down in our body. So this is how we should remember. 24 into PCO2 upon bicarb. We have to calculate HN by this formula, and another things. We have to see HN in that table, and we have to match that the HN concentration which is calculated by this formula and by this table is equal or not. If it is not equal, the ABG is not valid. We should not interpret such type of ABG. We have to repeat ABG. So we should not interpret it. Now see this example. So this example pH is 7.3. So first we have to check validity. So how to check validity? We have to calculate HN by formula. 24 into PCO2 upon bicarb. So how much PCO2 is 26? Bicarb is 22. So it will come 28.36. So this is HN concentration by this formula. And at this pH, we have to see how much HN concentration in this table. So can you see? So at this 28.36, the pH should be between these two values, between 7.5 to 7.6 at this hydrogen concentration. But our pH is 7.3. So it is not equal, it is different. So this ABG is not valid. Okay, so we should not interpret this ABG. Now, second step is, once ABG is valid, you have to look for pH. You can see pH is acidotic or alkalotic, acidemia or alkalemia. So any pH which is less than 7.4 is acidemia. If pH is more than 7.4, it is alkalemia. So we have to see this step number 2. Now step number 3 is, once you got pH, we have to see the cause for acidosis or alkalosis, whether it is metabolic or respiratory. I have told you for respiratory, we have to see PCO2. For metabolic, we have to see bicarbonate. So we have to check PCO2 and bicarbonate. And we have to check the cause for derangement of pH, whether it is bicarbonate or it is PCO2. So this is a beautiful table. In that you can see if pH is low, low means there is acidemia or acidosis. If there is high PCO2, means the problem is in the lungs. It is respiratory acidosis. If there is low bicarbonate, I told you bicarbonate for metabolic. This is metabolic acidosis. If pH is high, means there is alkalemia. It can be respiratory alkalosis if PCO2 is low. Because high PCO2 is acidosis, low PCO2 is alkalosis. If there is high SU3, it means metabolic alkalosis. So this is how we have to look for step 3, whether it is respiratory or metabolic. If it is respiratory, we have to see whether it's acute or chronic. Say, for example, COPD. So in COPD, it may be acute acidosis, it may be chronic acidosis, or acute or chronic. So we have to check whether it is acute or chronic. In acute, there is large pH change at little PCO2. But in chronic, there is little pH change on large PCO2. So we have to see, so we have to calculate the delta PCO2 and we have to multiply 0.008 and we have to calculate delta pH by this. If delta pH and the pH given in ABG is same, it means acute. If delta PCO2 into 0.003, we have to calculate delta pH and the delta pH is given in ABG same, it means this is chronic. So for acute, we have to multiply 0.008. For chronic, we have to multiply 0.003. So this is how we are going to see step 4. Step 5. If there is metabolic disturbance, we have to check anion gap. How to check anion gap? I'll discuss in subsequent slides. And after getting respiratory or metabolic, we have to check there is compensation. As I told you in beginning, there are 3 friends: buffer, kidney, and lung. If there is problem in respiratory, means respiratory acidosis or alkalosis, whatever is there, it will be compensated by kidney. If there is problem in kidney, means metabolic, it will be compensated by respiratory. Opposite, problem in PCO2 will be compensated by bicarb. If problem in bicarb, it will be compensated by PCO2. So, if there is problem in respiratory acidosis, it will be compensated by metabolic alkalosis. If there is problem in respiratory alkalosis, it will be solved by metabolic acidosis. If problem in metabolic acidosis, then opposite, respiratory alkalosis. So how much? Say for example, if CO2 is increased by 10, how much bicarb should increase? You have to remember composition is same side. If PCO2 is elevated, bicarb will also be elevated. If PCO2 is less, bicarb will also less. So same side for compensation. So every 10 increase in PCO2, the bicarb will get increased by 1. So you have to remember this formula. 1 is to 10, 4 is to 10. 1 is to 10, 4 is to 10, 4 is to 10. So in acute acidosis, respiratory acidosis, every 10 increase in PCO2 will get increased bicarb by 1. In chronic, increased 10 PCO2 will increase bicarb by 4. But same is not true for alkalosis. Alkalosis is 2,5. So In acute respiratory alkalosis, 10 decrease in PCO2 will decrease bicarb by 2. In chronic respiratory alkalosis, 10 decrease by PCO2 will decrease bicarb by 5. So we have to remember 1, 4, 2, 5. For respiratory problem will be compensated by metabolic acidosis or alkalosis. Now, if problem is metabolic disorder, means problem in kidney which is not able to excrete acid or whatever is there. So, if there is metabolic acidosis means less bicarb. Then how will it compensate? By wash out the CO2. So less bicarb, less PCO2 in the body. So how to calculate PCO2? PCO2 we can calculate by 1.5 into bicarb plus 8 plus minus 2. There's another formula, PCO2 is equal to 1.2 into bicarb. Means in one decrease in bicarb, the CO2 will increase by 1.2 times. But in metabolic alkalosis, increase in bicarb by 1 unit will increase PCO2 by 0.7. So metabolic acidosis 1.2, but metabolic alkalosis 0.7. We have to keep remember. Remember, body never overcompensate. So step 7, if there is metabolic acidosis and there is disturbance in anion gap, we have to check if there is other pathologies there or not. Means mixed acidosis or mixed acidosis and alkalosis. So we have to check gap ratio, also called delta gap. So we have to check delta gap. So these are 7 steps. So what are the steps? First, we have to check validity by this formula. Then look for pH, whether it's acidic or alkalemic. Then what is problem, respiratory or metabolic? Then if it is respiratory, acute or chronic. If it is metabolic, check anion gap. It is anion gap increase or normal. Then check for compensation. For kidney problem, respiratory will compensate. For respiratory, kidney will compensate. If there is metabolic acidosis, check delta ratio to find mixed disorder. So let's see case number 1. So she is known case of bronchial asthma. She came in acute exacerbation. So as I told you, never interpret ABG without clinical history. So this is the ABG. So what is the step 1? Step 1 is validity. We have to check whether this ABG is valid or not. How to check? This formula. So in this formula, we have to check by PCO2 is 24, bicarb is 20. So by HN consultation will come 28.1, and we have to check in this 28.8 how much pH is there. So pH will be somewhere here between 7.5 and 7.6. So pH is 7.54. It means this is valid pH. So we should go ahead. So this is acidemia or alkalemia. So pH is alkalosis. So the respiratory or metabolic. So you can see the PCO2 is 24, means alkalosis. If you see bicarb, this is acidotic. So pH is alkalosis, PCO2 is alkalosis. So this is respiratory alkalosis. Acute or chronic. So we have to check delta PCO2 and multiply by 0.003 and 0.008. This is acute one because pH is closer to 7.53. Now we have to see compensation. So as I told you, there is respiratory alkalosis. The compensation will be occurred by metabolic acidosis. Opposite. So how much compensation? As I told you, 2:10. This 10 decrease in CO2 will decrease bicarb by 2. So PCO2, how much CO2 is decreased? By 16. So how much bicarb will get reduced? 3.2. So the effective will be 20.8. In how much in our ABG is 20. So there is close. So there is no additional metabolic disturbance. So our final diagnosis is acute respiratory acidosis. So this is our final diagnosis. Now see case 2. He is 56-year-old male, came with anxiety disorder. Anxiety. So first we have to check validity. Validity, how to check? Again, PCO2 upon bicarb into 24, 36. And we have to see in table. So table 36 will come here, somewhere here. Okay. So this ABG is valid. It's no problem. Now look for pH. So pH is acidotic or alkalotic. So pH is alkalosis. So we have to see respiratory or metabolic. So we have to check PCO2. PCO2 is 20. So this is respiratory. Bicarb is 13.2. This is acidosis. So this is respiratory alkalosis. Now we have to check whether acute or chronic. Again, so we have to check delta PCO2 20 and we have to multiply by 0.008 and 0.003 and we have to see the pH is where is the pH. So if you multiply by 0.003, the pH will come 7.46 and if you multiply by 0.008, the pH will fall here. So our pH is close to chronic one. So this is chronic respiratory alkalosis. Now compensation. So compensation, how it occur? 5 is to 10. If there's decrease in PCO2 by 10, the bicarb will decrease by 5. So 5 is to 10. So how much bicarb? So how much PCO2 is less is 20. So bicarb should be less by 10. So 24 minus 10. How much? 14. In our ABG, the bicarb is 13.2. It should be 14. So nearly equal. So there is no additional problem. So the diagnosis is chronic respiratory alkalosis. So metabolic acidosis, we will see in part 2. Thank you. See you in part 2.